thing, usually they love to give him this wonderful thing called Go Lightly that does not go lightly at all. Because you are in that bathroom, let me tell you, okay, you are in that bathroom. Any one of you ever taken Go Lightly? Has anyone ever oh, there you go. They say, yes, you're right. Oof. It's a fate worse than death. But it does not go lightly. You sit in the bathroom, and when you think there is nothing more to come out of your rectum, bingo, there you go, there's more. And then, on top of this Go Lightly that we give, we also give you soap suds enema. And it's usually what, 2,000 cc's? Never mind the fleets enema. We're not going to do this baby stuff now. We're doing 2,000 cc's soap suds enema, and we are getting you so clean, you're going to be clean from your throat all the way down to your rectum, and you will squeak when you walk. That's how clean you will be. Okay? We got to do this. Why? Because we want to make sure. When we're looking, we want to see that there are no abnormalities. He also has to be NPO after midnight. And this person, you definitely also got to check stools afterwards. Again, you want to make sure he's passing out that barium. The sigmoidoscopy. Okay, the sigmoid colon, that's still lower GI. Okay, with the sigmoidoscopy, we want to identify any inflammations or lesions. You can also see if there's any cancerous lesions there. Nursing care, well, same thing before, the bowel prep, right? The laxative, the soap suds enema. You also want to tell him that during the sigmoidoscopy, actually it's the same with the enema, with any enema, whether it's a soap suds enema, barium enema, whatever. You also want to tell him that during the procedure, he may feel like he has to defecate. But tell him, trust me, you are so clean, there is nothing in there for you to defecate. You just feel like you got to. Okay. So there's the urge to defecate once he puts the scope in, or the enema tip, right? Or when they start infusing the enema. How many of you guys have given an enema to a patient? Okay, haven't patients said, oh, I gotta go, I can't hold it, I gotta go. Right? Right just as you start, the urge to defecate immediately arises. And the urge to defecate occurs because you've suddenly filled that rectal vault. That's where we get our normal urge to defecate. When that rectal vault is full, we gotta go. That's where it is, okay? After the sigmoidoscopy, you need to assess him carefully for any bowel perforation. So what does that mean? It means auscultate those bowel sounds. It means if he complains of pain, you need to tell the doctor, because bowel perforation could certainly occur. You want to check his vital signs. Okay? All those things you need to do. All right, number 5. Remember, we're going to do 6. This is number 5. Number 5 is when you have to collect stools for ova and parasites. The purpose of this stools for ova and parasites is to rule out or to confirm the presence or absence of intestinal parasites. Now, usually the doctor says O&P times 3. Now, it's the same thing. It's 3 consecutive bowel movements on 3 consecutive days, not 3 in the same day. Okay, so 3 consecutive. And you know what some people have done, and I saw this too. I mean, we had this patient that needed an O&P times 3, and we waited and we waited and we waited. I mean, this person only went to the bathroom, maybe twice, had a bowel movement maybe twice a week. So he finally had a bowel movement, and you know what the nurse did? All good intentions. All good intentions. Went in and got 3 little containers and got 3 samples and said, here we go, we got 3. Doesn't work like that. It's 3 consecutive days, 3 separate bowel movements, okay? You want to keep the sample warm and urine-free. Good luck. For NCLEX, though, urine-free, okay? You want to keep it warm and urine-free. You can refrigerate if necessary, if you need to. In other words, if you can't run it to the lab right away, you can refrigerate. But the ideal is to keep it warm and urine-free. Okay, now the question I get asked a lot is, okay, 3 stools on 3 consecutive days, but your patient doesn't go to the bathroom every day. So what do you do then? Well, it means 3. If he goes every other day, like Monday, Wednesday, Friday, then you collect it on Monday, you collect it on Wednesday, and you collect it on Friday. Those are 3 consecutive days of bowel movement. If he goes twice a week. He goes on Monday maybe, and then the next time he goes will be on Thursday. So you collect one on Monday, one on Thursday, and one the very next time that he goes, whenever that is. So those are your 3 consecutive days. You want to tell him that while we're waiting to collect stools for ova and parasites, if he's on any antibiotic therapy, and you will see ABT, abbreviation, antibiotic therapy, if he is on any antibiotic therapy, he needs to stop that antibiotic treatment 7 to 10 days before, because the antibiotic doesn't really kill the parasites, but what happens is that the parasite goes into hiding. Okay, it goes into hiding with the antibiotic treatment. And you want to tell him, if he takes any mineral oil or Pepto-Bismol, which is bismuth, bismuth is Pepto-Bismol, not to take it. And please don't schedule any barium enemas right before the stool, right before collecting the ova and parasites, the stool for ova and parasites. Okay, because that throws all the readings off. All right, the last thing that we're going to do is that hemoccult, which we talked about already. This is the first test that we do, isn't it? And the purpose of this guaiac, or the hemoccult, is to detect a GI bleed, and maybe it's maybe a possible early diagnosis of colorectal cancer. What is your nursing role in this thing? Well, your nursing role is, can you do this? Can you collect the hemoccult? You bet. You just put a glove on, go into the rectum, get a smear, and smear it on the hemoccult card. You want to ask him, though. You know, sometimes you get a positive, it turns blue when you put the developer, and that's a positive. You want to ask him, though, gee, have you taken any iron, or any Pepto-Bismol? Have you taken are you taking vitamin C? Are you on any steroids? Okay, find out those things. Find out if he's eaten a lot of liver, or a lot of beets, or horseradish, or red meat in the last few days. Maybe a false positive. Remember, hemoccult is not definitive. It's your primary test. And it gives you an indication of where to go from there if it's positive. All right, some common GI problems. Diverticulitis, diverticulosis, right? All those things. We're going to talk about that. We're also going to talk about Crohn's disease and ulcerative colitis. We're going to talk about hernias, esophageal hernias, inguinal hernias. Okay, these things are more and more common today. Esophageal and inguinal hernias. Do you know that? We're seeing more and more today. And you know why that is, folks? It's called the obesity factor in the United States. There are more obese people in the United States now. When you're obese, you run the risk of esophageal and inguinal hernias. We're going to talk about peptic ulcers, dumping syndrome, and the B12 deficiency, which we really already covered, but we're going to tie in B12 deficiency into dumping syndrome and gastric surgery now. Okay. First one, esophageal hernia, and this is my hernia. No, it's not my hernia, but it's the hernia that's a picture of the hernia. This is my hernia, okay? And he is an esophageal hernia. And the esophageal hernia is when part of the stomach protrudes through the diaphragm. Okay. What you've got to remember is when this happens, this guy's going to have heartburn, he's going to have pain, and he's going to have dysphagia, or difficulty swallowing. Okay. Some of the complications of an esophageal hernia are the same as with an inguinal hernia or any form of hernia. Okay? When you have a patient with a hernia, your nursing responsibility is as follows. You need to ask him, does it reduce? Or you need to find out yourself if it reduces. In other words, when you push it, does it go back? Okay, so does it reduce or does it stay? That's number one. Number two, are there bowel sounds? When you auscultate that hernia, can you hear bowel sounds? If you can hear bowel sounds, and certainly it is definitely part of the intestine protruding, but that is almost a good sign because it means it's not strangulated or incarcerated. If you don't hear bowel sounds, you're in trouble, he's in trouble, but he's also going to tell you he's in pain because an incarcerated or a strangulated hernia is extremely painful. So those are part of your nursing responsibilities. And of course, document what you found. If you didn't write it, you didn't do it. An inguinal hernia is usually a lump in the groin, and it usually occurs with some kind of strain or coughing or heavy lifting. Again, if it's strangulated, you're going to have a lot of pain. How do we treat Hernias. Well, there's a procedure called herniorrhaphy, and that's a repair of the hernia. My husband had one. Yep. So you have a repair of the hernia. It gets pushed back. You put a graft over it, the abdominal wall. You push the hernia back. What you got, and it's painful afterwards. It really is. What you want to tell people that after they have the repair, they are to avoid coughing and straining. So if they're going to avoid coughing and straining, what should you make sure that they have? Cough syrup on hand, right, to stop the coughing and straining, to stop the coughing anyway. The straining what? Stool softeners, because you don't want them to strain, yes? No heavy lifting for 6 weeks at least, and limit driving and stairs, because you don't know how many of your abdominal muscles you utilize when you drive until you've had abdominal surgery. And then you go to step on the gas and you go, oh my God, it's tremendous pain. Okay. Ask any woman who's had a C-section and they will tell you how much pain that is. And to avoid stairs. Okay. Heavy lifting, meaning more than, now that's up to the doctor, but generally it's no more than 10 pounds is a no-no. Some doctors will say 5, depending on the extent. All right, peptic ulcer. Well, a peptic ulcer is a lesion in the mucosa of the lower esophagus, of the stomach, or the pylorus, or the duodenum. So a peptic ulcer essentially is an ulcer somewhere in your GI tract. It is a result of an increase in the concentration or activity of the acid in your stomach, or a decrease in the normal resistance of your mucosa. Okay, let me try to put that in plain English for you. I know you would love that. Your gastric cavity is acidic. The acid that sits in your gastric cavity is something called hydrochloric acid. Very, very, very acidic. Okay, it can drop to as low as 1.5 in pH. It generally sits around 3, 4, something like that. Okay. What happens is that the mucosa of your stomach is very, very, very strong. It has to be in order to put up with that much acid, that higher concentration of acid. Well, with a peptic ulcer, something happens. Either you increase the production of your acid, it becomes more acidic than it normally is, or something happens to the integrity of the mucosal wall, and that deteriorates. Either way, it causes an actual erosion of the wall of your gastric cavity. It can also cause an erosion of your esophagus right there, the cardiac sphincter, where the esophagus connects with the stomach. So either way, it doesn't matter. What we do know is that because of something, okay, whether it's an increase in the production of the acid or whether it's a decrease in the resistance of the mucosa, you now have a lesion because the acid is now able to eat through part of the gastric cavity wall. Okay? What do you do? How do you treat a peptic ulcer? Well, in the good old days, it used to be they would tell you milk, milk, and more milk. Yes. Right? Milk and milk and milk and milk and milk. Well, my husband had ulcers. They put him on milk and milk. This was years ago. Milk and milk and milk and milk. He gained 30 pounds. Because they used to tell him, drink cream. Pure cream. You know how fatty that is? Because that will line your stomach. He gained 30 pounds and still is having trouble losing it. But I mean, that's what they told him to do. Well, today, what we tell our patients generally is that yes, certainly rest, and yes, certainly be careful of what you eat, but each patient's tolerance level is different. So, for example, you may be able to eat noodles with soy sauce and hoisin sauce, and that's wonderful, but she eats it and she has a peptic ulcer, she may have severe reactions. So essentially what we tell our patients is that you eat what you can tolerate. Obviously, we're going to advise them to avoid chili peppers, yes, and high spices, but essentially eat what you can tolerate. That's the going trend right now, and actually that is an NCLEX question. Okay, you advise the patient to eat what they can tolerate. Medications. We're going to ask them to take medications. Okay, you've got the basic medications of Amphigel and milk of mag. Yes, those basic antacids.